Good morning, everybody. My name's David Martin. I'm the chair of the Neurologist, and in my day job, I'm the CEO of the MS Trust. Thank you for joining us for this important debate and the first event of NeuroFest 2021. You probably know, but the NHS in England is currently undergoing some of its most significant reform for nearly a decade. The white paper, Integration and Innovation Working Together for All, sets out legislative proposals for the Health and Care Bill, currently at the committee stage in the Commons. That bill provides opportunities to improve people's outcomes and experiences of care, particularly for those in contact with different services, through better integrating services both within the NHS and across the health and social care system. The key question, however, is whether or not those reforms will deliver positively for people with neurological conditions and those closest to them. Today's discussion offers a great opportunity to consider these reforms in more detail, and I'm pleased to introduce a fantastic panel to help us guide through these reforms. So I'll now introduce the panels, and speaking for the motion first is Dr. Niran Nirmalanathan. So Dr. Niran, as I'm going to call him, is a consultant neurologist at St George's University Hospital NHS Foundation Trust in London, and he's also an honorary senior lecturer at St George's University of London. He's clinical director of the Atkinson Morley Regional Neurosciences Centre at St George's and clinical lead for the neuromuscular service and the headache service at St George's too. So welcome, Dr. Niran. Next, we've got Hazel Braun. Hazel is the Director of Partnerships and Change at the NHS Herefordshire and Worcestershire CCG. And then speaking against the motion, we've got Dr. Martin Wilson. Martin is the Consultant Neurologist and Divisional Clinical Director at the Walton. Martin has been as the Consultant Neurologist there since 2005 and splits his clinical time between general neurology and MS clinics, delivered at both the Walton and the Countess of Chester hospitals as well. He's the Divisional Clinical Director of Neurology at the Walton Centre, Digital Lead for Cheshire and Merseyside, and he also works as a National Specialty Advisor to NHSE. And last but not least is David Yandled OBE. David was diagnosed with relapsing remitting MS in 2010, but was informed last year that he's now moved to the progressive stage of multiple sclerosis. David is now retired, but before retiring, his most recent roles were the independent president of the United Nations Staff Management Committee, the head of employment policy at EEF, which is now Make UK, and the director of personnel at Pirelli Cables. A great panel. So before we move to the opening speeches, I'd like to ask you to vote for or against the motion. This House believes NHS reform in England could deliver integrated care for people with neurological conditions. Can I ask that you now vote, and that voting should now be open. There should now be a vote button underneath the chat box. I hope everybody's had a chance to vote. I can't actually see it on my screen. 100% for. 10 more seconds. Hopefully we'll be getting the result any minute now. Okay, we're closing the poll now. So the final results at this stage are 73% for and 27% against. So obviously we'll be doing that poll later in the debate just to see whether you've been influenced or not by our debaters. So an interesting start so far. So let's go for those. First of all, we're going to go to Dr. Niran and hear from him and Hazel about those in favour, those speaking for the motion. So Dr. Niran, over to you.
Thank you very much, David. I'm just sharing my screen. So I'm speaking for. I'm very glad to hear that the vast majority of people are in favour of the motion. Makes my job easier. So we're talking about how the NHS reform can deliver integrated care, and we're creating integrated care systems. These are the 42 new integrated care systems across the NHS. Just to be clear, I'm not advocating for the new health and care social bill, and I am not suggesting that this will solve the underfunding or workforce challenges in the NHS. But I do think there are considerable opportunities within the white paper, the long-term plan, and the National Neuroscience Transformation Team's plans for neuroscience services to better meet the needs of our populations. So just very, very briefly, I don't intend to go through the entire health and care bill, but there are three main strap lines. It's essentially to try and operationalize the long-term plan from 2019, which hopefully most people are familiar with. There are three strap lines: reducing bureaucracy and particularly getting rid of the principle of competition as an organizing principle in the NHS, increasing accountability of health services, which is rather controversial and does include giving the Secretary of State quite a lot of power over the NHS and to intervene in local health systems. But most importantly, from my perspective, supporting collaboration and integration. I'm just going to run through some of the key elements of that. So within the paper, we are having integrated care systems set up as the statutory bodies that replace the old CCGs. And from my perspective, this is a very positive development. CCGs were very much primary care focused with some element of community, but it's quite hard to engage with them as a secondary or tertiary care clinician. The new ICS bodies are essentially coterminous with the merged CCGs. So there were lots of CCGs in the NHS before. They're now largely merged into larger groups. And the ICS bodies bring together community, primary, secondary and tertiary care. But they also importantly have an additional arm called a health and care partnership, which brings in local government and social care partners, which is absolutely critical for joined up care. There's also really important new duty to collaborate. The previous structures really promoted organisations promoting their own interests. Trust boards had a duty to their own organisation rather than to the wider health system. And so you limited collaboration possible. ICSs now have multiple structures that really force that collaboration to happen. There are single financial control totals across a whole integrated care system, which will encompass multiple trusts and multiple LCCGs. There's single reporting of waiting lists, for example, which means that individual organizations are not competing against each other and can start to work together to try and manage long waiting lists. And that's already happening in our health system, certainly. There's a commitment to create joint committees so that NHS trusts and CCGs take joint decisions, and the old commissioner and provider split is being removed within integrated care systems. I think really importantly for neurosciences, there is a commitment to collaborative commissioning and to the evolution of specialised commissioning for things like neurorehabilitation and neurology, both responsibility for planning and budgets. And that's not to say that ICSs would take on all of that responsibility, but that they are partners with NHS England in the commissioning of specialised services. And it also helps us move away from a one-size-fits-all approach that's determined from the centre, which has led to a very significant disparity in access to care across the country and quite a large amount of unwarranted variation. The biggest concern I've heard from patients when talking about this previously is the loss of patient choice and their risk that their access to specialist care will be removed. The paper explicitly preserves the right to choose where and when and who will provide someone's health and care needs. But I think really importantly, it also allows ICSs to develop patient-centered services, which hopefully will mean that you can have new services that meet the needs of populations more locally and will ultimately provide greater and more local choice to patients. As part of all of that, the NHS specialised commissioning budgets are planned to be devolved. And the old commissioning model was really broken. Services were fragmented between NHS England and specialised services and CCGs, and very much determined by where care was delivered. So a specialist seeing a patient in a district general hospital could not deliver specialised care as NHS England defined it, but the same person seeing a patient at a regional neuroscience centre could. And that really leads to a lot of care moving to the regional specialist units. And just as an example, in my own region, with 8 trusts and about 3 million population, about 50% of all outpatient appointments happen at my hospital rather than in the district general hospitals or community. That cannot be right. The new model, this is a figure from the NHS England Specialised Transformation Team, tries to move specialist care away from tier 3. So there are 3 tiers here: general and local neurology, which was previously CCG commissioned, and then specialty clinics and highly specialised services, which were previously NHS England commissioned. And the plan is to move a lot of the specialist activity to ICS level, with the most specialised tier commissioned by NHS England restricted really to the really highly specialised services, such as neuromyelitis optica services, with support for regional MDT meetings. So I think that's a really important change. And I think just to illustrate how this could be operationalized and developed in practice, we in South West London and Surrey have been working with the NHS England Transformation Team on the national pilot for neurology specialised services delegation. And just to illustrate how things could change, our current proposal, due to start early next year, is that we have a network already that brings together tertiary, secondary, primary and community services across 2 different integrated care systems in 2 different NHS England regions. We want to use a principles-based approach, so we will have timely access to specialist neurology services regardless of where patients lived. We're going to be really focused on repatriating care within the region so that care is delivered as close to home as feasible for patients, and that we're collaborating between organisations on the basis of population health benefits, focusing on the patient's experience and efficiency of service delivery. That will be delivered through network care and specialty MDTs across all major chronic condition pathways, so that we get much earlier recognition and diagnosis in the local hospitals, district general hospitals, where you've got specialist Parkinson's clinics, specialist epilepsy clinics, with early access to specialist treatment and support for more local delivery of specialist follow-up, such as, for example, programming of deep brain stimulators within currently non-specialist centres. We're also going to be using new workforce models and using the merged specialised and CCG budgets to try and provide a greater focus on community support, and particularly case management for complex chronic neurological conditions. I think it's really, really important that we have an alignment with neurorehabilitation pathways. And again, our ICSs have committed to a redesign of neurorehabilitation. You cannot do neurology transformation without thinking about disability management and rehab. And it's really important also with the specialised delegation that we think just as much about community and outpatient pathways as we do about inpatient pathways. And finally, the ICSs have also allowed us to work in a way we've never been able to before with the mental health services, because they bring together mental health networks with the physical health networks. We've also had our ICSs fund and patient co-design group for us, and so we plan to co-produce these transformations with patients, carers and families, and use the new integration to collect the data we need, because current data available on the NHS is not really fit for purpose for neurology. And I think I have to be very clear, we've been working towards this for years, but without these new reforms, almost none of what I've just suggested would have actually been possible within the old systems. So in summary, I think the reforms support and encourage health systems to work much more collaboratively. They remove that old focus on individual organisations and shift that to systems, which ultimately means shifts that to patients. It legislates to support system-wide collaboration. It removes perverse incentives and disincentives that previously existed. It decentralises commissioning of what should have been and should be local services where possible. And hopefully it will reduce unwarranted variation. Finally, just as a big caveat, reform is necessary, but it is not sufficient. And it is absolutely essential from my personal experience that there is strong and wide-based clinical leadership, not just from neurologists and neurosurgeons, but also from primary care, community providers, therapists, psychologists involved in patients' pathways. And it's really important that there's strong patient and community engagement from the outset. But I'm very optimistic about these changes. Thank you.
you very much. An excellent presentation. And before we go on to Hazel, just want to update one or two people are having some sound and vision problems. So Georgina is sending out a new link. So if you perhaps want to try that link and also ask you to refresh, but we are being advised by our experts behind the scenes, if you're still having problems, maybe you can try a different browser or maybe try viewing on your phone. But if I can apologize to you for any issues they might see. Right, now for our second speaker for the motion this morning, we've got Hazel Braun. Hazel, over to you.
Thank you very much. First of all, I want to thank you for inviting me to take part in this important debate. It's a real privilege to be amongst such an expert and experienced group of people, both on the panel and in the audience. I believe that the Health and Care Bill offers the opportunity for people with neurological conditions to benefit from the improved integration of the care they receive through the great emphasis on collaboration in their local communities. And Dr. Niran has talked a lot about how the bill works. So I'm not going to go over the bill. What I'm going to do is give you a practical presentation with just a couple of slides about how we're doing this in the rural Herefordshire and Worcestershire, which I think in that map that Dr. Niran showed us at the beginning was slot number 17. So we're virtually in Wales. We border, Hereford and Worcestershire borders Wales, Shropshire, Gloucestershire and up into Birmingham. We are a very rural population, and my focus is very much on what we're doing collectively in that local community. So as we develop at place, so and I think Dr. Niran has talked you through the structures. One of the important things about the bill is that it is highly permissive and flexible. So we're a very small ICS. We're only 800,000 population, which is one of the smallest. And what that means is that we only have 2 places, and our places are coterminous with our county councils. My focus is in Herefordshire, and I'm going to focus on Herefordshire because it is a very rural county. It's the 4th least densely populated county in England, which brings challenges in itself. The 2 ways that I think the changes in the bill will in particular support us in supporting people with neurological conditions is firstly through the closer working between the partners and stakeholders in local communities. And this slide talks a lot about that. And the second opportunity is through the opportunity that the clinicians and partners in the integrated care system will have to participate in the commissioning of specialist services. And I'll come on to that as well. And Dr. Niran has talked about that as well. So if we look about your experience or any patient's or member of the public's experience of care, we do have significant organisational boundaries between health and social care still, between health organisations, and also we have boundaries between the wider between the organisations that are responsible for delivering the wider determinants of health. As we move into establishing our place, we're bringing all of those partners together. This isn't just about how care is provided, it's also about how people are supported to live healthy and happy lives in their own communities. And what we're seeing in our rural communities and also in our cities, we do have cities in rural Herefordshire, really beautiful city, really beautiful cathedral. And what we are seeing is, for example, far more engagement around the housing needs of our population, far more interest in how we work together and how we have shared priorities in areas that we've always touched on as a health system, for example, in working with our colleagues in the police around community safety, through working with, as I said, our housing colleagues in ensuring that people have got adequate and appropriately enabled housing to support whatever their needs are. But the bill does give us both the impetus and the wherewithal in terms of how we do that and how we focus. So this slide just highlights some of the areas that we feel that will really help us with. So for example, we've hopefully that you would have begun to experience the impact of primary care networks, where we're fairly well developed now in bringing practices together to build their resilience and also to support them in understanding the issues in their population. So if we think about that sharing of data, intelligence and insight at a primary care network level, which will cover around 50,000 people, that will allow us to think about and to understand how many people in that population have neurological conditions, what their current experience is. And I'm sure that in rural counties, and we know that in our county, that there are challenges in terms of accessing specialist services. Our transport infrastructure isn't as good as it should be. And quite often the dialogue that happens between our local clinicians and those in specialist centres aren't as good and as effective and regular as they should be. We'll have a much better opportunity to understand those and also to then wrap services around people in a way that we've talked about for a long time, but we've never quite managed. So there is a real drive to do that. I just want to move on to my second slide, because I think the flexibility in the Act can work against groups such as the Alliance in terms of, unfortunately, if you allow 1,000 flowers to bloom, it does make it difficult to know where your entry point is in each place if you're wanting to pursue a particular issue. So in Herefordshire, we've developed a community partnership that is facilitated by our local Health Watch and includes on it a group of VCS patient and public representatives. And we're asking them to seek feedback, and then they have a direct influence into our place partnership, which is the One Herefordshire partnership here. We also have the Health and Wellbeing Board, which remains a statutory partnership at place level and will link in with the ICF partnership board. But of course, it does have huge influence. It includes our elected members, and the way that the bill operates, and as Dr. Niran referenced, it does bring together those partners, but it means that those elected members become far more influential on the local and also on the ICS partnership board. So there's a real opportunity for patients, public and professionals to influence. We then move to the Integrated Care Board, which is the accountable body, which people from our One Herefordshire partnership, our leadership team, will sit on. And they will have this joint commissioning board for specialist services that Dr. Niran referenced, in terms of that's how we will begin to have an opportunity to learn about and to influence our specialist services. And that will then go into the specialist commissioning board. It is a simple representation, but actually one of the things I think this bill does is it does simplify our understanding and the way we work, simply by pulling some of that decision taking to a place level and far closer to our population. It does mean that at even a small place level, and Herefordshire has a population of 190,000, we do have a far more direct route into gaining that understanding, both of our local population, but also of the wider issues that our colleagues providing specialist services are able to give us. So I'm going to stop sharing my screen now, and I'm going to just sum up. I think I'm a bit over my 5 minutes. And just to say, there are lots of opportunities in this bill. As with many bills, this isn't the first time we've heard about the opportunities that integration bring. But arguably, this bill does actually provide us the framework and the permissiveness that should allow us to actually deliver that far greater joining up of services, so that all of our patients should see improvement, but in particular, that direct line through to specialist services, I believe will give us a really good opportunity to improve the lot of people who have neurological conditions. Thank you very much.
Hazel, thank you. And another really strong presentation. So we've had two very good speakers there putting the case for the situation where we're going to have the NHS reform in England could deliver integrated care for people with neurological conditions. It sounds to me like we're going to have a nirvana starting next year and beyond, or maybe things might be slightly differently. So next, we're going to go to Dr. Martin Wilson from the Walton. So Martin, over to you.
Thanks very much, David. Do I need to reshare my screen, or is that still on there? I'm going to assume that you can see my slides and hear me, unless someone shouts out. I can only see what I'm seeing on my screen because of the way this works. So thanks very much. So so this House believes NHS reform in England could deliver integrated care for people with neurological conditions. I think not. So I'm going to run through, and I'm going to try and stick to my 5 minutes, which my opponent absolutely didn't. I'll just leave that there. What do we mean by integrated care? Is that a good thing? And then is NHS reform the way to achieve that, which is what the brief was. So we've talked about this already. So I don't want to go into this too much, but these started with the service and transformation plans or service transformation partnerships. No one really knew what to call those or what they were or what to end up calling them. But we've ended up calling them integrated care systems, so ICSs. And the idea of these, I think we're probably aware of, so they're really about removing divisions between primary and secondary care, tertiary care, in particular between the NHS and social care, so between NHS and local authority services. I've highlighted that deliberately. I think that's felt to be one of the big problems with the current system and one of the big wins. But also between physical and mental health and others, so ambulance services, voluntary sector, social enterprise organisations, and so on. And the benefits of that, I think, are apparent. So a seamless journey for the patient or the client, if you're coming from a social care perspective. We use different languages, which is just one of the many problems facing us with this. Things will be more efficient. There are opportunities for shared workforce, for avoiding duplication of services. And that all makes absolutely perfect sense, and I will say very clearly and openly that that is a good thing. But what are some of the barriers to achieving this? Because I think there are many. So organisational and cultural things. So you can legislate as much as you like, but there's a lot of history here, isn't there? And if you look at social care and healthcare in particular, these are staff groups, organizations, buildings, information systems that are completely separate, and legislating and calling a region something is not going to change that. And if you look at the example there of mental health, which is already within the NHS, there's no legislation that stops mental health and physical health from being integrated or talking to each other, but we don't. What about resources? So this is a big change, and big change needs lots of resource. And I've used the analogy here of the deck chairs on the Titanic, and that's a lot of deck chairs. So if you look at an example for the Manchester project, which is one of the first of these, so Devo Manc, you probably remember, one of the first places to try and join up health and social care. This was primed because it needed to succeed, and with £450 million, if you replicated that across England, that's £11 billion just to fund getting things set up. Right, informatics and information. So I mentioned this because again, the flow of information is absolutely vital for this. If patients and service users are moving between services, the flow of information, whether you're talking about referral letters or discharge summaries or other patient information, is absolutely vital. And there are going to be massive challenges for getting that information moving between these different organizations. Again, whatever label you attach to a region. And the lessons from the National Programme for IT there, I think, should teach us something about centrally driven change not working, which we might touch on later if we've got time. And related but separate to that, there's information governance. So that's not just about the digital stuff, but just again, the rules governing flow of information between different bits of the system. And I mention that because this is already should be sorted. We already have a duty to share. But even though that legislation is in place, the reality is very, very different. And we've already got massive challenges sharing information, even between bits of the NHS that should be working together now. So primary care and secondary care, physical health and mental health, and the money. So, again, we can put the legislation in place, but you're still going to have budgets that currently one bit of the system holds and another bit holds, and who's going to give up their bit of money and give it to someone else? There's going to be a lot of vested interests there that are going to be very difficult to overcome. So the question is, will the health and care bill solve this? So as others have said, we've now got these 42 integrated care systems. So mine is Cheshire and Merseyside, for example. These were confirmed in April of this year. Did anyone notice? I'm not sure I did. And they're going to be fully operational statutory bodies, apparently, by April coming. So everything will change then, I guess. But you may know that some of these have been operating as pilots for quite some time, since about 2018 or sometimes even before that. So we have got some experience and some evidence from those that we can use to tell us what we're likely to achieve. And there's a few things that you can measure with that, but one of them is DTOC, delayed transfers of care. So the usual term used for this is bed blockers, which is not a very nice term because it sounds punitive on the patients because they're not their fault, but I think we all know what we mean. So people stuck in NHS beds because they can't move through to local authorities' social care beds. So that's felt to be a key marker of this working and breaking down those barriers between the NHS and social care. So in these pilot sites, so what happened? So nationally, this was getting worse anyway. So they rose by 9%. But in the pilot sites, they actually rose by 24%. They were worse, not better, than the national average for delayed transfers of care. What about emergency readmissions? So people are discharged from NHS and then readmitted because, again, indicating failure of the system working properly. Again, those are actually above the national average. And what about efficiency and workforce? Well, there was a 20% increase in appointment of senior managers in the pilot sites. I'll leave you to decide whether that's a good or bad thing. What about evidence from previous reforms? Well, 2012, remember the Andrew Lansley Health and Social Care Bill? That got rid of PCTs and we went to CCGs. Again, a massive deck chair reorganisation, which cost hundreds of millions and achieved pretty much nothing apart from fragmenting an already fragmented system. The National Programme for IT, I don't want to say too much about that, but except that, again, it was an enormous waste of resource and actually a missed opportunity. But I don't think we have time really to go into that. But the point is that there's not a great record of legislation and reform achieving what we actually want to achieve, even if that is agreed to be a good thing. So I'm going to sum up. I think there are numerous barriers that central reform, so NHS reform, central reform legislation cannot address. We've got evidence of poor previous experience of that to back that up. And we've got actual objective evidence from even the most advanced pilot sites that it won't work. But you might say that I'm being, pessimistic. And one of the key things which Niran mentions as well is leadership. So with inspiring and effective leadership, possibly I am being too pessimistic. You must be joking. And that's all I have to say. Thank you. I will stop sharing my screen.
Thank you very much, Martin. Wonderful presentation. It's great to get a smile there at the end as well. So we've heard from two people working on the front line. We've heard from a commissioner. Now we're going to hear from one of the most important people of all of all, and that's somebody actually living with a neurological condition. So David Yandle lives with MS at the moment. He's going to give his perspective on this reforms and why he thinks that perhaps they might not deliver nirvana. So David, over to you.
My name is David Yeandle. I'm speaking against a motion for the NeuroFest21 debate. The motion is, this House believes NHS reform in England could deliver integrated care for people with neurological conditions. As someone who was diagnosed with relapsing remitting MS just over 10 years ago, I've since had a lot of contact with various parts of the NHS, as well as with the private health care sector for services such as regular physiotherapy and psychological support that are not readily available for me locally. More recently, I was told by my MS consultant that I have moved to the progressive stage of MS, and since my mobility has deteriorated, I also now had to seek the support of adult social services. I know from both my personal experience and from speaking to many people with MS how important it is for people with chronic neurological conditions like MS to have holistic and integrated care. Unfortunately, this is rarely the case, as they find that rather than there being a single integrated system of care, services are provided by a patchwork of organisations that sometimes work together, but unfortunately sometimes do not. As we are all living longer, an increasing number of people with neurological conditions also have multiple health care issues. They therefore need support from many different services, often at the same time. This requires these services to work together to provide joined up and coordinated care, which meets an individual's needs in a flexible way. The government should be congratulated for at last trying to grasp this nettle through the reforms to the organisation of the NHS that are set out in its Health and Care Bill, as well as the recently announced additional funding for the NHS and social care sector. However, this falls far short of the oven-ready plan for social care that the Prime Minister announced on the steps of 10 Downing Street after the last general election. As one commentator has stated, it requires a scale of ambition well beyond the government's current proposed reforms. Like many others, I feel that the way in which the government is planning to raise these additional funds for the NHS and social care through increasing employers' and employees' national insurance contributions is unfair. This is because, for example, it means that while low-paid NHS and care staff will pay these additional NI contributions, they will not be paid by wealthy people whose income mainly comes from dividends or house rentals. In addition, many commentators have questioned whether the money raised is enough, as well as when this money will, as the government has stated, be transferred from the NHS to the care sector. However, there are also some serious gaps in the government's plans, which could unfortunately torpedo the achievement of its objectives. This is because there is no attempt to tackle the workforce crisis that both the NHS and the care sector are now facing. Unless and until this crisis is faced up to and addressed, it is difficult to see how the government's proposed reforms can realistically lead to the system of integrated care that is needed. This will, amongst other things, mean encouraging the recruitment of more staff, both locally and from overseas, as well as ensuring that staff in both the NHS and the care sector are well rewarded with good career structures. In my view, it would also probably require the public and private providers of health and social care to work more closely together. In conclusion, the government's current plans can be seen as a step in the right direction. However, there are a number of serious problems which must be addressed if they are to lead to the holy grail of providing integrated and coordinated care for people with neurological conditions.
David, thank you very much. And another excellent presentation. So 4 really good speakers there. I think it's going to be interesting to see which way this vote goes, because obviously there's some key issues on both sides, whether it's going to be nirvana, whether there are some challenges that are not necessarily going to be ironed out in the next 12 or 24 months or so. So in a few minutes, we are going to throw to you to see if there's any questions that you perhaps want to ask of the panelists. But first, we're going to give 2 minutes to each of the panelists as their point of rebuttal. Because each of them, apart from one, apart from David Yandle at the end, has overrun in their session. I'm going to be strictly timing their session, so they're going to get a strict 2 minutes each. If they're still talking after 2 minutes, we should be pulling the plug to ensure that we get time for some questions at the end of that. So, Dr. Niran, first, we're handing back to you. So, 2 minutes for a rebuttal, starting from now.
Apologies, I was on mute. I'm not going to try and rebut everything because I don't disagree with everything that either Martin or David said. There are clearly significant workforce challenges in the NHS, and there are, I think, finance and budget is a really core issue. Without investment, this won't work. However, I think it is clear from a financial perspective that if you invest earlier in pathways, you can make savings further on in pathways. For example, if you manage patients with migraine earlier on, they don't develop chronic migraine and they don't need high-cost drugs, CGRP blockers, for example, for treatment of their migraine in the numbers that they otherwise would. So there are opportunities within the current restrictions, but I completely agree that more funding is required and that system-wide planning is required. For social care, I'm not going to address that. I completely agree with David's points. I would say that in terms of Martin's comments, the 13 ICS pilot sites did their pilots without any legislation, without any structures to enforce collaboration within their geographies, and so I think they were actually in a very different position. One of the 3 ICSs I work with was one of those pilot sites in Frimley, and it was an extremely challenging environment. I think there were changes in local authority boundaries and other things that prevented them working as closely as possible, and that's no longer there from my own experience. I don't disagree that previous NHS reform was a challenge, but what I'm suggesting is that the new NHS reforms are permissive, and in particular the point about central reorganisation not working. This is one central reorganisation that is reducing central power and giving power to local communities and local patient partnerships and local clinical partnerships. And I think that is the real core of the opportunity here. I don't think I've got very much else to add. I think the other challenges are there, but if we've got local control and local collaboration, we are better able to navigate as a group, clinicians and patients together, and commissioners together, a otherwise extremely challenging environment. Thank you.
Okay, so that's only 2:17, so maybe we need to get some stopwatches for Christmas. Dr. Niran, thank you. That's a good rebuttal. Next, over to Hazel Braun. So Hazel, you've got 2 minutes.
Thank you, and I won't take 2 minutes. I do agree with a lot of what Martin and David said. I think Martin, I think you're a little too pessimistic, and I'd really like to invite you to come and visit us, because I think the point about inspirational leadership and also the commitment in a place to have a common purpose that focuses around the broad holistic needs of the individual, recognizing that environment and the wider determinants of health are absolutely key in supporting any group of people, but also that we can have influence on specialist services. And I think for a lot of the time certainly in the last 10 years, where local commissioners and clinicians haven't had a voice in specialist commissioning, I think they have really walked away. But I think now there is a voice and there is an opportunity. But this is all about opportunity. I think in our local system, we've got great leadership and we've got huge commitment to a common purpose, and that will make the difference. Thank you.
You'd think I'd know this by now. Thanks, Hazel, and thank you for sticking within time as well. So that's the case for the question. We're now going to go back to Martin. So Martin, you've been told you're being a little bit pessimistic. I'm sure you're going to deal with that in your rebuttal. Back to you.
Thank you. Yes. Well, it's perhaps a realistic view, I think, perhaps rather than pessimistic. But I don't disagree with a lot of what's been said by Niran and Hazel, and I think we're all agreed about the objectives here and the aims. And the question is whether reforms, NHS reforms, whether they're national or even regionally led, will achieve that. And a couple of things were mentioned about reduction in bureaucracy. I think we've seen evidence already that could actually increase, not decrease. And Niran mentioned specifically this new duty to collaborate, and I think that is important. But we've already had that before. We've had the duty to share information, and what you've seen is the reality is actually very different, and it just does not happen. And I mentioned before that we've already got examples of that within mental health versus physical health, and in terms of the information governance, where there's already ample legislation and support for all that to happen seamlessly, and yet it doesn't. So my point, I think, is that we all agree on the aims, the objectives. If we can achieve that, it's not NHS reform, and certainly not NHS reform alone that will do that. And that's really my point. Thank you.
Martin, thank you for either being realistic or pessimistic, whichever way you want to put it. And last but not least, so we've got David Yandle giving the patient's perspective on the rebuttal and for the case against. So David, over to you.
Thank you very much. I've got 2 points I want to make, I think, really. First of all, the model proposed may look attractive to deliver integrated services, but I'm afraid we cannot ignore the very serious workforce issues that there are in both the NHS and social care. And if those are not addressed in a very urgent and coherent fashion, I can't see any likelihood, from my perspective, that this sort of services will be provided. In my area, there are real gaps in physiotherapy, in psychological, and there is absolutely very lack of neurorehabilitation services. But the other point I want to make is, as an HR professional, before I retired, I have had lots of experience of managing change, not in such a large organization as the NHS. And I know from my experience there that organizational change is very complex. It's very difficult to deliver. It requires really firm and clear leadership. And I share the comments that we haven't really got that. But most importantly, there is a danger in my experience that organizational takes precedent and takes people's eye off the ball of running and providing services during that period. And I think it's inevitable that it's going to take an awful lot longer, especially post-COVID, than anyone envisages. This is not something that's going to happen overnight and cannot happen overnight.
Thank you very much for that reality check. That was really helpful. Now we've got a chance for a few questions before we go for a final vote. So just to remind everybody, the vote is going to be for or against the motion. This House believes NHS reform in England could deliver integrated care for people with neurological conditions. You are very much for that. Right at the beginning of this session, you've had four very persuasive debates and speeches this morning. We've got chance now for a few questions. I've got one initially from Aaron Cox, and Aaron asked the panel, the position is focused on if it could, but do you agree that it's more about whether the NHS and the wider care system should and whether it actually can change in a meaningful way? Panel, any thoughts on that particular question from Aaron before we get some other questions coming through as well?
I'd like to start there if I can, please. So,
Hazel.
What I'm seeing is a real shift in leadership understanding and a ceding of power. And I think actually one of the bravest things a leader can do, either a clinical leader or a managerial leader, is to hand power to other people. And I think some of the greatest chief execs I've worked for over the years have been those who are prepared to share and hand over power. And I think that's what we're beginning to see, early stages, and I do agree it'll take time, but I am seeing that, and I think this framework does allow us to do that. It offers the opportunity, it enables the decision-taking body in the ICS to hand power across, and then in the community, in the system, for the different leaders to share and cede power.
Okay, Dr. Niran.
I was just going to agree with Hazel. I think one of the things that's striking to me in the last year or so, since we became ICSs, is that my power within our system is significantly less than it was. I communicate with my GP colleagues far more than I used to, with our community teams far more than I used to, and we make collaborative decisions about the investments that are required across the system. And just as a clinical manager who's worked in NHS management for about 7-8 years now, this really does feel different to me, just from a personal perspective. The way I'm working with my colleagues is with a sense of common purpose. So I think it is a could and it is a should. We can and we should.
So Martin, is it feeling different to you?
No, not yet. So the question about whether there should be change, I mean, I agree absolutely with that. So this arbitrary massive war between social care and healthcare is a nonsense, and it's risen for arbitrary system. And I think it's partly risen because, of course, we need to remember that local authorities do a lot of other things, and fund a lot of other things, and have responsibility for a lot of other things that we're probably not interested in at all, but and don't need to work together on. But in terms of social care, yeah, absolutely, we should do that. We should do that. My point is more about the can, and I think the barriers I've outlined are about the reality of whether that can happen.
Well,
okay,
I would agree that we should bring these two together, but I share Martin's point that I question whether there is really the political determination to do this, and at the end of the day, I come back to what I said before. You can have the best organizational structure in the world, but if you haven't got the people to deliver the services in a coherent fashion on the ground, nothing is going to change. And I think there are really serious problems about workforce in so many different aspects of this. It takes far too long to get things. For example, it took more than 9 months from when I was referred by my consultant for me to get a wheelchair delivered. I mean, that is just dreadful. And I know it's an experience that's all too familiar to people with neurological conditions. And it's just simply lack of money and people and resources. It's not necessarily about organizational change. It's lack of resources in so many ways.
Thank you, David. Niran, I saw you indicating, but I've got one final question. Got a great comment from Anne who's saying changes to systems, recycle the personnel. It doesn't change their knowledge, their information, and their attitudes. But I've got another good question. We've got about 2 minutes before we go to the final vote. And this is Caroline from Gain. And Caroline's asking, could this reform actually create and probably make worse, I'll add my words added in there, a postcode lottery and reduce the care in some areas? That's something I've heard about over the last month or two as a potential. So perhaps somebody from each side would like to respond to that. We've got about a minute before we go to the vote. Niran, is there anything you or Hazel would want to say?
So there are two different questions there. I'll just answer the second one. So I think at the moment we have a huge postcode lottery already. So I think if NHS England's National Transformation Team's estimate of spend on neurology per capita is between £55 per thousand, £50 pounds per 1,000 population in one area to 19,000 in another. I mean, you cannot possibly get worse than that inequity of spend and access. So there is a risk, and it is really important at a slightly central level that there's some strategy and oversight to try and push people to try and reduce health inequalities. But this is in parallel with Public Health England being devolved to regional teams. I think we can analyse health inequalities within systems more effectively than we could do. I'm certainly seeing much more public health data and inequality data than I've ever seen before. And I would hope we can improve, but I think it is a challenge, but it can't get worse than it currently is. The second point I would just make in terms of investing in change is that we can continually bring more people in to deal with waiting lists, but it's essentially running on a treadmill. You just keep seeing more and more and more patients rather than thinking about which patients need to be seen when, whose wheelchair needs to be prioritized now, as opposed to an appointment for something else. And you need to think, you need some brain space to think about the problem rather than constantly trying to firefight, which is what people are currently doing. And I think this gives us an opportunity. It's not the answer, and I totally agree with the comments about workforce and finance, but it does give us an opportunity to change things.
Okay, and Martin, yeah, it sounds like he's very persuasive, isn't he? Are you going to agree with him this time?
No, not entirely. I think the just about postcode losses and access, there are potential risks with this, absolutely, because you're clearly defining borders, aren't you, of ICSs, and in some areas that's relatively straightforward and they match local authority ones. In some areas they don't. Some ICSs are very big, some are very small, so some ICSs will kind of match a neurology footprint if you look at the sort of the rarity and otherwise of certain conditions, and Cheshire and Mersey where it kind of matches that, but there's lots where it won't. So you're going to have a small ICS where you potentially got to have some services working across different ICSs if you can have access to services, and that's going to become difficult. The patient choice issue is a very interesting one because that's still enshrined, and yet the the budgets are going to be, you're going to have a budget for an ICS. So why should we start seeing patients as we refer patients all the time from outside our area? And in the past we always used to say yes, come on, because the money follows the patient. But now that's all changed, and it's going to be the same with ICS. So there definitely are going to be risks of people being a bit geographical and looking at boundaries a bit more, not less than they did before.
Right.
I would agree that I see little indication that this is going to reduce the postcode lottery. Indeed, it could make it worse, I would suggest. And one other thing that I think and no one has talked about is, I know from my experience, and I know from talking to many other people, how difficult it is for patients to navigate the NHS and social care system. It is really complex. Frankly, far too many people just give up. It's just too difficult. If you're someone like me who's prepared to sort of push around and use your sharp elbows, it's not too bad. But if you're not used to doing things like that, people just give up and get forgotten. And there is a real out in the field, there are an awful lot of people with neurological conditions who are just not getting any care whatsoever.
That's worrying. That's worrying, David. David, time is pressing on us now, so we're now going to call for the vote. So if I can just remind everybody of the motion, the poll is now live. So this House believes NHS reform in England could deliver integrated care for people with neurological conditions. So you've had your earlier vote. Now time to decide, have you been influenced about what you've heard today? So the poll is activated. Please make your views known. Thirty more seconds, please, just to put your vote through, and we'll share the results with you just before we wrap up and thank our wonderful speakers today. Intriguing to see whether the poll has moved or not. Persuasive speakers from both sides. Ooh, that's interesting. That is really interesting. Okay, so the results are in. And whereas initially we had 73% for the motion and 27% against, things have moved. So we've gone to 62%, so 38% for and 62% against. So really intriguing, really intriguing. Well done to our winning team. But thank you to all of you for your very helpful contributions and insights for the debate. So we have recorded this session. I hope the recording can be shared, but I have asked each of the panelists that they'll also be happy to share those slides as well, which I thought were insightful. So it's clear, isn't it, that the reforms offer opportunity, but there's a lot of work to be done, including by us, everybody here today, and everybody in the neurological community, if we are to make the most of them. And I think there's a role for the Alliance in policing what happens ahead. You've heard from all of our speakers about the need to engage effectively with stakeholders at all levels, about the need for good evidence in order to support effective reform. And some areas would need more attention, particularly social care, which we've heard time and time again today. Clearly, we need to work together if we're going to realise the potential of this reform and offer constructive challenge to the system. Here at the Alliance, we stand ready to engage. Thank you to our wonderful panelists, to Dr. Niran, to Hazel, to Martin, and to David. And thank you to all. And a reminder that the video from today will be available for 30 days from now, should you wish to watch it back, or indeed share it with your colleagues. And if you haven't already, please have a look at the other events which are taking place during November's NeuroFest, which are on the Neuro Alliance website. Thank you and have a great day.